Is it available for poor countries like Vietnam, Myanmar, Thailand, Cambodia, Laos, in our region in general? The second thing is how can we get the patient at the angio room? She may be very happy about that, I know, because one-stop stroke is another dream for all of the stroke patients. But is it available? Is it available? Because now we skip the CT scan, we skip the MRI, go directly to the angio. But the angio, is it not simple? Is it not normal angio? We need everything, combine CT scan, combine rapid system. Is it available? So you will say something. So especially, I would like to introduce my great colleagues. Rosa Bly will share the first mention about the mobile stroke units. How is the system in US now currently?
Hear me on the mic now? Okay, great. Well, I just want to start by thanking you for being here, Kung. But yes, so the mobile stroke units, I think the application for mobile stroke in the US right now is really accelerating the time to give someone TPA. So it's like, I think of it like a portable hospital that can make the diagnosis quickly and then deliver TPA in the field. And it also obviously identifies our large vessel Siemens, and the crew are obviously working hard to give us a great image quality in the ambulance. As we know, there's a lot of technologies that are doing that to better identify our large vessel occlusion patient, in the field. And then obviously that dispatch and getting them to a thrombectomy capable center is much, much easier. So they can come directly here than stop at a network hospital, and that obviously delays our treatment time. So it's still a work in progress, but I think we're understanding more where that, where in the field identification is going, and then also, the application, like you were saying, of on the table angio and perfusion capability. So taking a person directly to the cath lab, doing your screening and evaluation there is again, something that we're understanding. What patient population do we take directly to the lab? So yeah, I think it's still work in progress, but yeah.
Is available for the poor country. I don't know. What's about the Thailand? Any colleagues from Thailand? Anybody? Malaysia? What do you think from Malaysia? Mobile stroke units?
In our country, we are just about to start the mobile stroke unit. We have a little bit of issue with the regulatory on the size of the ambulance, on the patient radiation protection, because it's still not incorporated with the other agencies in our country. But we are preparing for and I personally believe there are values, because cases which have thrombolysis and thrombectomy is quite significant percentage in our cohort. So it might be helpful to have a thrombolysis first and followed by the thrombectomy later in some of the cases.
Yeah, great.
And what about Indonesia? Do you have any plan for mobile stroke units?
Actually, we do not have the mobile stroke unit currently, and I think in the short term, we did not plan to have that kind of service, because we still focus on delivering or increasing the number of hospitals who can do thrombolysis and thrombectomy, sir.
I would say something to consider when you're, beginning on the mobile stroke unit application is where do you dispatch the mobile stroke unit? So I think you want to think about that, because it's obviously a valuable resource, but if someone just says, I think the patient is having a stroke, often that very valuable resource isn't going to a true positive stroke patient. So I think you want to figure out a little bit of a stroke screening triage that you do before you dispatch the unit. So it's almost using our LVO detection scores or those kind of things at an EMS level when they get that call, so that there's a higher percentage that the mobile stroke unit will go to a patient that actually is a true positive stroke patient.
We don't accept the Robin hospital without the CT, without the MR, but had the rapid angio. I think so. So personally, I think that especially for our region, for the poor country, we need to be has good people, network building, and training the people to know about the stroke. And immediately I sent to nearby hospital. And the US guy, fortunately, I don't think 100% of the region has a mobile stroke so far.
No, so
yeah.
it's
only some.
Yeah, very regional. So even there's a mix between, it's mostly and obviously very metropolitan centers, but there are some more rural-based centers that are using it, but yeah, it's not all over, and not used all over the country for sure. Yeah, thank you. Okay, well, great. Well, like I said, I thought I'd begin by just doing a little bit of a flashback. I'm very, very, very happy to be here at the Stroke Intervention School. For me, it's a very special thing to see what has been accomplished by Kung and colleagues in Vietnam. And here's going down memory lane a little bit. This is many years ago. I think I see less gray hairs on the gentleman on the left, but we began our journey of working together. We've had some good bonding moments of partnership. So this was a visit, again, several years ago to the Mekong Delta. And, well, I'm getting my computer message here. Let's see. Somebody wants to control my computer. I probably should deny that, shouldn't I? Oops, is it? Okay, I'll switch over to this. I think I've aged a little bit more. Kung has not aged that much, but I don't know if we're on a journey to begin to look like these two. But I'm so proud of what has been accomplished here in Cần Thơ and in Vietnam, and what is going on in Asia Pacific in general with how you have basically taken stroke to a new level. We're learning from you. The design of the hospitals and what you're accomplishing with pushing technologies is amazing. And so it's great to see what you've done in this area and how you're serving your patients. But it's great to see other familiar faces in the room from different practices. And so, like I said, thank you for having us here. And it's special for me to share this with a colleague, Dr. Darren Schaff, who we've had the privilege of working together. I've worked with Darren, and we've been enjoying the food journey here. One of the things that we've been exploring is where do we get the durian? We had a little durian this morning, so yes, durian for breakfast I think is definitely the way to go. I'm going to switch it up. I'm going to give actually the talk that I was supposed to give tomorrow now, and I'll flip that around if that's okay, Kung. But I'm going to just give a little update on where we are in selecting patients, and I won't be talking about the mobile stroke units in that part. We all know our history. We all know that really these trials, these 5 trials back in 2015, changed all of our stroke practices basically in 1 year. 5 New England Journal of Medicine published trials showing the effect of thrombectomy really brought in a new standard of care for stroke patients. And what we didn't really know is how powerful a treatment effect that we unlocked. In medical history, this is one of the most powerful treatments that we've ever seen. It's on par with the discovery of antibiotics. It's if you look at STEMI and the Organization of Heart Disease, their number needed to treat is about 1 in 17. We're at a 1 in 2.7. It's an extremely powerful treatment. And if we look, what is more important for this talk, if we look at who benefits from this treatment, it's almost impossible to find who doesn't benefit, right? So when we were first looking at who we would treat, now it's like, okay, who shouldn't we treat? Because if you look at, these forest plots, basically every subset, if you look at age, if you look at, what your baseline core infarct is at the beginning, if you look at whether or not they had IV tPA, the location of the occlusion, your stroke scale score, everything is to the right, saying that treating these patients is favored with thrombectomy and recanalizing an occluded vessel. We also have the benefit of this is a very safe treatment. If we compare it, so hey, what's the downside? In other words, of pressing on, is it that it's a more risky procedure for the patient? It's actually shown to be very safe, in our treatment analyses and trials. So really where we focused on the sweet spot at first. We focused on patients that we thought, hey, they're gonna have a good outcome. Their time from onset is relatively short. They have a small infarct burden at baseline. So we were kind of picking the sweet stuff. And as our treatments have gone on, basically we are now, we use that information from the trials to obviously the guidelines come out, and the guidelines said, okay, we're all very familiar with this, that we, should treat patients that have a low stroke, low pre-stroke disability. The occlusion is an M1 or ICA. So again, in these guidelines, there was no mention of posterior circulation strokes, more distal occlusions, age, stroke scale score 6 or greater. We all see patients in our practice that have a lower stroke scale score than that and do have a large vessel occlusion. Aspect score, the guidelines reflect that the patient should have a relatively small core infarct at baseline. But what about the patients that have a little bit bigger core infarct? Should we be treating them? And then treatment time, within 6 hours of onset. Well, we know that we've done the trials to change that as well. So if we were to stick with just the AHA guidelines, we would treat about 15 to 20% of the patients that we have coming into our hospitals. So we can see that there's a lot of territory to really expand, into other types of, patients that present to us that have large vessel occlusions. And as I said, the natural history of this disease is so poor. In other words, if we just let this patient go on and have their large vessel occlusion, they do so poorly that we really need a reason why we wouldn't treat that patient. And so that's what we're kind of looking at now. At first, with the trials, the gate was a little narrow, but we're now looking at, hey, who do we expand this treatment to? And so that's what I was going to talk a little bit about. There's a term I don't know, if you're familiar, but fringes are things that go around the edges, so who are our patients that are kind of on the edges, so to speak, now of getting treatment? I mentioned that if you look at what's in the guidelines for, ideally treating a patient within 6 hours, I mean, that is a good metric to aim for, but we know that we can screen patients and treat patients beyond 6 hours. Time is not, like if we just said, hey, let's cut the clock off here on a patient treatment, that would not be good for, we would miss a lot of patients that can have a very good outcome. If we group number 2 and 3 here just as location of occlusions, we haven't done the science to broaden our treatment out. We all know that basilar arteries, I mean, horrible natural history. I mean, we treat them every day, but we haven't, done the trials to show that. And those trials are coming very shortly. And these distal occlusions, M2s, even M3s, P2s, that needs to be sorted out. Again, I mentioned, patients that have a decent infarct at the time of their presentation, larger than what we used in the inclusion criteria for the previous trials, should they be treated? So that's where I'm going to focus the talk, is a little bit on these trials that are looking at patients that come in that have a bigger stroke infarct burden at baseline, and how treatments are looking. Are they doing better than no treatment? And then the patients that present with a low stroke scale score, they do have a large vessel occlusion, but they come in and they look relatively good. I mean, should we or shouldn't we treat those patients? So the first bar that we took down, so to speak, was just basing treatment and patient selection on time. And we kind of know this story. Time is brain. We say that a lot. But the main thing is time everything. In other words, should we just say, okay, we use 6 hours, we use 8 hours, 12 hours. I'm going to show basically in these slides, here's the different ways that patients will present to us that all have an M1 occlusion, and they're all basically the same time from onset of their occlusion. But they have very different presentations. So we see patients that come in, they have a relatively small amount of dead brain or core infarct, but their penumbral area is kind of matched. It's pretty small relative to the whole territory that should be involved. So they have a small mismatch. And they have a low stroke scale score. We have these patients that come in and they have again, a pretty small core of dead brain, but they have a very large area that's at risk or penumbral, and they're coming in with maybe a very large stroke scale score, so they have a large mismatch. We have patients that will present this way. They have more of the area already looks like it may be permanently damaged, but there still is some penumbral area that they could grow, if you like, and more brain that's at risk. Large stroke scale score, but a smaller mismatch. And then we have patients that come in and they have a very large area of brain that's already dead. There's really no penumbral area, so there's no mismatch to treat. So if you look at this, these are all the same time of onset and all M1 occlusions. What's the difference? Well, the difference, as we know as treaters, is collaterals, right? So your brain has this ability to obviously immediately kick in a compensatory mechanism. So if you look at the person that, to your left that comes in and has basically a very small amount of brain that is infarcted, small penumbral area, they're tolerating their M1 occlusion, in other words, very, very well, and they have a low stroke scale score. The question always comes up, will those collaterals exhaust over time? Should we go and open that vessel? What's going to happen? They look good now, but where are they headed? If you look at the next, person, that's really the person that we aimed all of the trials at, was having a large mismatch. So this is where we have our science is in this zone. We have a larger stroke scale score, a large mismatch. This group, the low stroke scale score, and this group, the ones that come in with a larger core but still have brain that could be salvaged, This is where the trial activity is really happening right now. So these are the patients that were fringe patients, but this is where we're pushing. This is really the group that we want to identify and say, they're probably, you know, if it's dead brain is dead brain. I've proved that to myself many times. If you recanalize a vessel and all the brain is dead, you're not going to turn that around. So it's really how you identify, you know, the patients that absolutely won't have a good outcome versus these other categories. So we talked about collaterals. I mean, as soon as you include your M1, you're basically you know, kicking in a very robust collateral supply. And this varies, and this is just physiology. So again, trying to say, okay, let's pick patients based on time and different, you know, we have to understand, you know, individual physiology and capabilities to do collateral flow. We all kind of know that there are things that are slow, there are things that are fast. And that's the same with how your brain infarcts or dies during an occlusion of a vessel. Some people are slow infarctors, some people are fast infarctors. We've all seen patients that, you know, come in within a very quick time window. You know, this patient less than 2 hours from symptom onset. We do the perfusion imaging. Basically, it's a match defect. It's all dead brain. They're, you know, matching the penumbral area. Go ahead and open the vessel, and patient, you know, has a very big infarct. So we aren't able to do much in that scenario. So that patient falls under the category. It was an early time, but they had poor collaterals, and they have a poor outcome. They're a fast infarctor. Versus these patients that come in and they're, you know, late, if you like, late onset, late window patients. Screen them, they have a small core, large penumbral area, so a good mismatch. And we go ahead and open the vessel, and even though it's 16 hours after symptom onset, they have a smaller infarct, and they do very well. So, you know, late time, good collaterals, you still offer, you know, the patient a chance to have a good outcome because they're a slower infarctor. So the concept of just, you know, that was the first thing that we kind of addressed, the concept of time is brain, and let's just use time as our guide for patient selection, was really an oversimplified concept, you know, because you have all of these variables that are affecting, you know, the rate that a patient will have their brain die, so to speak, so, and bringing them into these categories of fast infarctors or slow infarctors. So, as we all know, we sort of, you know, did the trials. The first ones to expand the guidelines were all focused on time. You know, Dawn trial, Diffuse, all of these basically looked at that subset. This was a pooled analysis of that data, and reflecting that, you know, that these patients do have good outcomes. If we screen beyond 6 hours, the guidelines got changed to reflect, hey, you know, expand the patient selection, include these patients or screen them in the later time windows because they can benefit from thrombectomy. So, you know, that's number one. Okay, so that work has sort of been done. If we jump down, I'm going to just show, because in the current trial activity, we're really have most of the evidence coming in from the larger core infarct population. And so if we look at these patients that come in with an aspect score of less than 6, you know, what's going on? Well, there's a lot of trial activity that's happening in this patient population. Most of it is focused at, again, if you think back to that slide I showed where the whole area, whole territory, whole MCA territory was dead brain. Those are kind of the aspects of 0 to 2. So most people agree that's probably not somebody that we're going to, you know, is going to benefit from reopening the vessel. In most of those patients, actually, it may be harmful because it's all dead brain. You reperfuse dead brain, and you probably, you know, significantly increase their hemorrhage risk. So these trials all, you know, kind of use aspect scores of 3 to 5, you know, 3 to 6, but 3 to 5 is kind of the sweet spot of, okay, these patients, we haven't been offering, you know, by the guidelines, thrombectomy, but, you know, will they benefit? They still have some area of brain that is salvageable, and do they do better if we open those vessels? So one of the first ones is kind of hot off the press, a New England Journal publication just from this past April, was the group from Japan. And I thank Shinichi Yoshimura, who's a good friend and colleague of ours, for giving me this data to kind of share. But they did the Rescue Japan study, and this was looking again at a randomized clinical trial that was done at multiple centers throughout Japan from 2018, the fall of 18 to the fall of 2021. And the study design was to specifically look at the aspects score of 3 to 5, and it had all the usual inclusion criteria. Their goal was to have 100 patients in the endovascular treatment group, 100 in the control group. The difference between our previous trials a little bit was that they went for a primary outcome of a good functional outcome. So instead of an MRS of just 0 to 2, they expanded that to an MRS of 0 to 3. And so going through this, they basically had 235 patients that were eligible and screened for the analysis, and that took them down to, when they went through all of the different kind of non-consents, et cetera, they had 94 in the treatment group and 94 in the no treatment group. So close to where they wanted to be. I won't go through all this in detail. I'm just showing you the data. You can look at this, but very, very evenly matched for every parameter: age, baseline MRS score, baseline stroke scale score, occlusion sites. So the population was a very matched population. They were able to accomplish a very fast reperfusion time from onset. If you look, they're about 6 hours from a stroke symptom onset to when they have the vessel open, which is very good from an efficiency point of view. And they were able to achieve a TICI 2B or greater score in 86% of the patients, so they had good recanalization results. And how did they do? From the achieving the primary endpoint of the trial? Well, they showed very nicely that in this group with a larger core infarct at baseline, that if you recanalize these vessels, that the functional outcome significantly improves. So this is absolutely a patient population that we shouldn't be excluding from treatment, that there was a very clinically significant improvement in outcomes with thrombectomy. If you look at this is kind of an analysis of the secondary outcomes. So if you look at an MRS of 0 to 2 being a good outcome, if you had that as your benchmark, the trial still would have been, reflecting that EVT outperformed no treatment. And if you look at an excellent outcome as well, more patients achieved an MRS of 0 or 1 with treatment than without. So definitely there's a delta or an ordinal shift towards treatment and the benefits of treating. Safety. As expected, more of these patients, they have a bigger area of dead brain at baseline. So you do see more bleeding on MR, CT, all that ECAS reported bleeding that people report. But for symptomatic ICH, there was really no increase in the worrisome PH2 bleeds that we don't like to see that would clinically take a patient backwards. So and then very favorable, if you look at the mortality rates, et cetera, were in favor of treatment. This is probably one of the more important slides, because now we're looking at this group that has a bigger baseline core infarct, and you see that still, if you take every subgroup, okay, should we not treat people that come in with a larger core if they're over 75? Is age important? Is time from onset? Is there a stroke scale score? Did they get tPA or didn't they? Everything favors treatment. So everybody, all these subgroups seem to benefit from treatment. There's nobody that you would exclude. And one of the things that they said, when they're going through some of the limitations, just to think about with this study, is that they, in Japan, predominantly use MRI for screening their patients. And so they were calculating the aspect score based on MRI, which, as we know, diffusion weighting is maybe more sensitive than looking at a CT scan. So they kind of wrote a paper on that, saying that probably when they were picking, a 3 to 5 aspects on MRI, that may be the equivalent of a 4 to 6 on a CT scan. So they're, one of the differences would be, looking at aspects on CT versus MR. One of the other things was that there's a chance for error in assessing aspects by the ER physicians that were looking at a lot of these scans kind of real time and making treatment decisions. The treatment assignment wasn't blinded for patient or physician. And, they said that possibly this data may not be that generalizable, based on the Japanese population. They use a lower dose lower number of patients, maybe got IV TPA, some limited racial diversity, and again, the predominant use of MRI for screening. But I think, this science is pretty solid, that we know that I think these results are transportable to other populations. So, the conclusion of this study was basically that EVT increased independent patients by 2.43 times over medical therapy or no treatment in these large vessel occlusion patients. And that again, the ICH group was more, but symptomatic ICH was not significantly different. So that was looking at, expanding and looking at trials for assessing larger core infarcts. I'm not going to spend any more time on updating, because the data isn't in yet, but we have trials that are focused on distal clot locations. There's the ESCAPE MEVO trial and distal. If you look worldwide, this is another group of patients that there's kind of equipoise in whether we treat or don't treat. In other words, people feel, okay, M2 occlusions, do we just, do TPA alone, medical management alone, or should we go in and open the vessel? We don't know which way to go with that, so these trials will help us there. And so in closing, as treaters, get ready, because as we expand to all these different patient populations, we may be sleeping in our in our angio labs, or we may need a little bit of this to keep us going. So I'm going to close there, and thank you very much for your attention. And if you have any questions, feel free. Any questions or anything? Or